for RWJBarnabas Health and the director of the Matthew J. Morahan III Health Assessment Center for Athletes. I wanted to welcome you all to our Grand Rounds presentation this morning, and thank you for joining us so early. Today we're going to be covering concussion and facial hypoesthesia, and we're really excited to have a very engaged and multidisciplinary panel to support this topic. We have a very unique case to review today that I think all of our panelists are going to be really able to add something very unique in their perspective on brain injury medicine. Being part of the Morahan Center for the last 10 years and leading a great concussion program across the state of New Jersey with a lot of our medical leadership, we're just really, proud to be able to offer a program like this that I think kind of leads the charge on thinking a little bit out of the box as it relates to acute concussion. So I know many of you are probably on the road dropping your kids off, trying to get to work. So for all of you that have joined us so early this morning, thank you. And just a couple little reminders and housekeeping items. We are going to have an upcoming event that we wanted to share with all of you, so please just keep it in the back of your minds as a save the date. On October 1st of this year, we're going to be offering our first sports medicine annual symposium. It's going to be a half-day CME and CEU event where everyone will be able, to kind of get some professional credit and also learn a little bit about lower ligamentous injuries. We're recruiting a really high visibility panel for that right now, and so more to come on that. Some other things to just bring to your attention. Please keep in mind this is a professional credit offering. So if you are here for CME or CEU credit, please stay on for the full 60 minutes. We do have to account for that when we are issuing you credit. And keep an eye out for an email within the next 7 days from our team on how to get that credit. We will contact you in order for you to get your certificate. All right. Additionally, our question and answer section, just wanted to bring your attention to that. I'm sure we're going to get some great questions today. You should have a Q&A option on the bottom of your screen. Some of you may have it on the top, depending on your display. Just make sure when you go into Q&A, you address the question to all panelists and not just the host, so that all of our team can see it today. All right, so besides that, I think we can jump right into our introductions. So I'm going to start with our supportive panel and then go into our keynote speaker. So first we have Dr. Jan Claes. Dr. Jan Claes is a doctor of physical medicine and rehabilitation with Rutgers, New Jersey Medical School. And I will start by saying all of our panel today are faculty within the Rutgers RWJ Medical School. So Dr. Jan Claes is also our chairman of physical medicine and rehabilitation at St. Barnabas Medical Center. And he is also specialized in traumatic brain injury. So we're very, very privileged to have him today. Good morning, Dr. Jan Claes. Thank you for joining us. Next, we have Dr. Andrea McKay. Dr. McKay is also a member of the physical medicine rehabilitation staff at the med school. She is Associate Program Director for the Brain Injury Medicine Fellowship there and also a member of the med school faculty. Good morning, Dr. McKay. Thank you for joining us. Next, we have Dr. Jason Womack. Dr. Womack is Chief of our Division of Sports Medicine within the med school. He is also the Director of the Sports Medicine Fellowship, and he is Team Physician for Rutgers Athletics. Dr. Womack, good morning. Thank you for joining us. Next, we have Dr. Raul Pawar. He is a member of our diagnostic neuroradiology faculty. He's also faculty of the med school, and he is a member of our board of trustees with St. Barnabas Medical Center. He will be joining us shortly to go over some of the imaging. And next we have Dr. Mike Heitzman, known as Dr. Mike from his patients. He is a doctorate of physical therapy, clinical physical therapist and supervisor. He is our concussion program team supervisor and team lead, and has been great in helping to develop some instrumental rehab protocols for our patients. Good morning, Mike. And finally, we have our keynote speaker. I'm going to turn this over to Dr. Jason Krystofiak. So I have the privilege of working with Dr. Krystofiak day in and day out as the medical director of sports medicine at St. Barnabas Medical Center, as well as the medical director of the Morahan Health Assessment Center for Athletes. Dr. Krystofiak is also assistant team physician for Rutgers Athletics, and he is also faculty within the med school. His professional interests include electrocardiogram screening in athletes, concussion, osteoarthritis, corticosteroid injections, and musculoskeletal ultrasound. And he's going to do an amazing job presenting this case. Dr. Krystofiak, thank you so much for putting this together. The show is yours.
Thank you, Diana. Thank you to everyone who's attending this morning, and thank you for our panelists for joining. You guys are awesome. It's a pleasure to work with all of you. So I just want to make sure that my, am I good to share now? Okay. Perfect. Okay, great. Diana, can you just verify home slide looks good?
Looks great, yes.
Great. Some of the things we have to worry about in the virtual world of COVID-19, but here we go. So I do not have any disclosures. Just a quick overview. I'm going to be doing a unique case report and then briefly discuss acute concussion evaluation, discuss neurological screening within a concussion evaluation, go over neuroimaging criteria, and then we're going to further engage our panel to answer some questions and then open it up for a Q&A. So I'm going to start out, and this is going to be a typical case presentation. So chief complaint. So I was one of the last patients I was seeing in the office on a Wednesday night about a year ago. She was a 20-year-old female. She presented with a headache, and for a concussion evaluation, she was referred from an emergency department. For her HPI, again, she was a 20-year-old female. More in depth, she was a Division I collegiate soccer athlete. She had a history of 2 prior sport-related concussions and a history of migraines without aura. She was playing in a pool with her friends about 3 days earlier. She sustained a forced flexion injury when someone jumped on her from behind, and she acutely developed some significant neck pain, and she had multiple concussion symptoms. Because of her history of concussions, she kind of didn't think too much of it. She thought she was just going to stay home and see how things went. She did not have any loss of consciousness. Later on that evening, she did feel like she was getting migrainous-like symptoms that were pretty significant. About 2 days later of just being home and resting, she did develop right-sided numbness throughout most of her body, and she was starting to have some issues with word finding. That prompted her to go to the emergency department, which is nearest her house down south. The emergency department evaluation was within normal limits. They did do a CT head without contrast because of her symptoms. It did not, it was, the acute read was normal. There was no bleed or any other intracranial abnormalities. She was discharged with a diagnosis of acute concussion and questionable complex migraines just because of the numbness that she was having and her history. Now, I saw her the next day in the later afternoon. So she actually did go back to the emergency department, the same emergency department the next morning with worsening of those symptoms. And again, the evaluation they felt was normal. And again, she was diagnosed with an acute concussion, questionable complex migraine. Going into her history a little bit further, she had no learning disabilities, ADHD, mood disorder, or motion sickness, no prior neck injuries. She was doing complete cognitive and physical rest at home since the injury. She did try taking Imitrex because of what she felt like she was having a breakthrough migraine. And then when I was seeing her, she was complaining of a worsening headache, but she did not have any vomiting or nausea or feel weak anywhere in her body. And of note, there was no prolonged immobilization or surgeries within her history. Review systems was unremarkable, unless I already discussed. For her past medical history, I already discussed, she had 2 sport-related concussions. They were soccer-related. She had no residual issues with those concussions. The migraine is without aura. She was, and she has a history of mononucleosis as well. Otherwise, a relatively healthy 20-year-old. No surgeries in her history. She had no medical allergies or environmental allergies. And for medicines, I mentioned Imitrex. She was using Excedrin migraine. And to note, she was also on an oral contraceptive, Trilosprintec. For family history, there was no remarkable family history that's pertinent to this case. No history of stroke, TIA, or any type of hypercoagulable disorder, or any type of other major health issues. For social history, she, again, was extremely healthy, exercised daily, very fit, no drugs, alcohol, smoking, no supplements, no recent dietary changes, nothing of note. On her physical exam, just for the pertinent positives, just for the general, she was well appearing, but on 2 occasions I did observe that she had word finding difficulties when she was giving me her history. For her neck exam, she had no midline spinal tenderness. There was no step-offs, but she did have pretty significant bilateral cervical tenderness, and her range of motion was decreased in all planes, and she did have multidirectional pain. For her neurological screen, although visualized no focal deficits, she did have sensation to light touch that was decreased, and most of her right-sided dermatomes that went from her face actually down to her ankle level. They were more prominent at the upper portions of her body. The rest of the neurological screen, her strength was 5 out of 5. Her cerebellar testing was normal. Her deep tendon reflexes were intact. The rest of the physical exam was unremarkable. So some of the concussion testing that was done on site during the visit, and some of this was actually done prior to me actually seeing the patient. She had a symptom score with a common symptom score analysis of a 57, which is in the mid to higher range. For her vestibular ocular motor screening, it was considered pan positive. So she had issues with smooth pursuits, horizontal and vertical saccades. Her convergence was significantly off. She had vestibular ocular reflex issues with horizontal and vertical testing, and she had visual motion sensitivity issues as well. For her balance error scoring system, which is done as a double leg and a single leg and tandem analysis, she had no errors with double leg, but she had 5 single leg and 5 tandem. We did not have a baseline for this analysis, but per the patient, that this was significantly different than what she would have expected. Normally, when we see patients for concussion evaluation, depending on the time frame, we do a Buffalo concussion treadmill test. This was not performed because of her reporting acute numbness that was worsening on the right side of her body, as well as the word difficulties. Her King-Tevic testing on the iPad was prolonged, but she did not have any errors following the sequences, and her impact neurological screening or cognitive screening test was pan positive as well. Issues with verbal memory, visual motor, as well as her reaction time was significantly delayed. So, when you're looking at all this with the history, this is screaming concussion, basically, when you're looking through all this concussion testing data. So I just want to take a moment to just take a break. So at this time, I basically have all the information. I've done my neurological assessment. I have a full history on this individual. The mother's in the room and pretty much borderline hysterical because she really feels that something is significantly wrong with her daughter. She had 2 visits to the emergency department, and she just can't figure out why she feels so much different than she felt before. So I just want to kind of open this up to the panel and just get some thoughts about differential diagnoses that might be going through your mind. Audience, please, if you can use the chat function or the Q&A function, if you want to throw some differentials in too, well, we can just take a minute to do that. Any takers?
I'll just make a comment about, like, this presentation for this patient. I mean, I think with these are challenging when you get, a lot of these specific type of symptoms, when you have somebody that has word finding difficulties and you have some focal neurological, even though questionably how focal it is, these are challenging, and this is a patient that I'm glad did get further evaluation, compared to, a lot of concussed patients we don't send on for more emergent eval and imaging, but this is a patient that I am happy had that because of some of those specific findings. So, we've had some patients and talking about differential diagnoses with, word finding difficulties and stuff like that. Sometimes epidurals and subdurals, even epidurals, we always think of them as the severe, loss of consciousness and severe, morbidity. But I've seen a few that are not quite as severe as it's taught in the textbooks that present with some of these subtle findings. And often they're missed on the initial CAT scan, and sometimes will need to be followed up, 6 to 8 hours later. So sometimes you'll see these in clinic the next day. You do have to think, was the initial CAT scan too early or not?
I would agree with that comment. Yeah, I think with the focal neuro findings, you certainly have to entertain something more central. And Dr. Womack is right. In our trauma institution, we'll often image again in 24 hours. If there's somebody still having persistent symptoms with an initial negative head CT, if we're more concerned, we'll do it earlier. But this certainly speaks to something else going on. And I think it's tough sometimes to differentiate or separate out those patients who have multiple concussive symptoms, but she has had a history, and this clearly seems different, that should make you more concerned.
Yeah, I would agree completely. I'm very interested in gender differences and how that impacts recovery from concussion. And, a lot of times in our female athletes, I think people have the conception that they may always have higher symptom scores, and so they may not always seek out further imaging and further workup for them. So I'm glad that this is definitely a tough case, and I understand why people might feel that it was a complex migraine based on our history, and that could be a continuation of this with their symptoms. But I'm glad that because of the focal neurologic findings, that more imaging was done, and it is tough.
Great. Thank you for sharing. That's great feedback. So I hope the audience was able to put together maybe some, differentials that you're thinking about just to kind of get things moving. When we were initially making the the problem list, it was concussion without loss of consciousness. It was a right hypoesthesias on the right side, word finding difficulty, and cervical strain were just the problems. But obviously extremely concerning given her presentation, her worsening symptoms, and just generally her presentation, just having to have really right side hemibody numbness going throughout, and the word finding difficulties, and someone who had some form of a trauma, whether it was unclear, definitely warranted some more acute evaluation. So I was really concerned with this individual. I sent her for a stat MRI of the brain without contrast. I actually did do a stat cerebrovascular duplex as well. There's been some cases of when you have such a forced neck flexion injury, you can cause damage to some of the arteries within the neck itself. And although getting a stat more advanced imaging of the neck sometimes is possible, getting a duplex does give some information. So that was done in a stat fashion. It was a great job by the staff to be able to pull all this off. The family was a little suspect about going back to the emergency department for a third time because they already had 2 trips. So if anyone's in the audience saying this is a clear red flag, go right back to the emergency department. Trust me, I did try that route. So the initial imaging results, the MRI of the brain without contrast did show a acute left MCA territory infarction. There is no hemorrhage on the official read. There is no classic features of traumatic brain injury. The actual duplex study of the neck did not show any type of concern for dissections, abnormal flows. There was no stenosis anywhere. So here's actually some of the brain imaging from the initial scan. Dr. Poir, are you on?
Yes, I'm here. Can you see me?
We'll see you now. You already been introduced. Hey, how's it going? Diana introduced you already. We're really happy to have one of our neuroradiologists on who is looking at this initial imaging to go through some of the next few slides with us.
Well, great. Thanks for having me. So far, a wonderful presentation. I'm covering the neuro service as we speak, so this is time appropriate. So looking at these initial imaging studies, the further left image, the middle image, and there's 3 images on this slide. So the first 2, left and middle, are the diffusion images, the B1000 images, and the corresponding ADC or the apparent diffusion coefficient map. So these 2, the diffusion imaging is read in conjunction. You have to read the B1000 and the ADC map together. In true restriction or diffusion restriction is defined as parenchyma being bright on the diffusion images, the B1000, and dark on the ADC map. Now, true restriction can be seen with a multitude of pathologies. Stroke, infarct is perhaps the most common, but diffusion restriction by definition refers to the diffusion restriction or limited movement of water molecules in the extracellular environment of a cell system. So in a stroke, for instance, there's the failure of the sodium-potassium pump, which then limits movement of water molecules. That gets picked up on the diffusion images in areas where there's infarct, where the cells have died, and but other things can restrict as well. So I tell the residents not all that restricts is a stroke. But in this particular case, if you look at her diffusion images, you can see that there's a gyriform, meaning it's conforming to the contour of the gyri, a gyriform pattern of acute restriction involving the posterior insular cortex at the level of the basal ganglia. You're sort of at the parieto-temporal junction, and that is arterial-wise the MCA, the middle cerebral artery distribution. So the initial imaging showed a gyriform pattern of acute restriction in the left MCA territory. And looking at this, even though it's a young patient, it is highly suspect for an acute infarct. Now, the other things, depending on the clinical context, that can mimic an infarct are cerebritis. But patients have cerebritis are quite sick. Patients that are having grand mal seizures that are actively seizing can have what's known as post-ictal phenomenon, where it can show up as diffusion imaging, but that's usually seen in the medial temporal lobe. And tumors can also restrict, but this doesn't have the classic imaging pattern of a dense tumor. You know, lymphomas can restrict, but those tend to be either extraaxial along the dura or a deep white matter. They don't typically look cortical like this. So this is by and large very reminiscent of an acute stroke.
Right. And then moving on to the next set of imagings, there's FLAIR and SWI.
Right. So the FLAIR images, which the FLAIR stands for Fluid Attenuated Inversion Recovery. That's a very fancy way of saying that we're going to image the brain, which is largely water, and edema, which is bright, just like water is bright. It can be hard to separate the two. So the FLAIR image is basically a subtracted image where we remove all the normal appearing zones where there's water signal intensity. So if you look at the ventricles, they're black. The extraaxial space is black. That would normally be bright on conventional T2 imaging. So, but the edema, which is not pure water or not pure CSF, remains bright. So the FLAIR image demonstrates the gyriform edema pattern, which conforms to the pattern of diffusion restriction that you saw in the preceding images. The susceptibility weighted imaging, or SWI, is far more sensitive than the conventional gradient imaging that we use to detect hemorrhage. It can be used to detect other things as well, such as mineralization, calcium, heavy metal deposition. But in the setting of evaluating for a stroke, we always look at the susceptibility or gradient images at the same time to see if there's areas of dark signal intensity where there's diffusion restriction, because that can signify hemorrhagic conversion, hemorrhage from other causes, and so forth. And on this particular case, the SWI image is, on this particular slice at least, is negative for hemorrhage.
Great. And now we moved on. This is another SWI image.
So on the SWI image, you could see all the sort of loopy and wiry dark signal intensity along the surface of the brain. Those are actually veins and arteries, but mostly veins carrying deoxyhemoglobin, and they show up as dark. On this particular slice, there's a very, very subtle bright spot overlying an insular and left MCA insular branch. And it's almost impossible to differentiate artery from vein, but moving forward as we evaluate this case, retrospectively, it seems that this bright focus may in fact reflect a tiny embolic thrombus within an insular branch that's feeding, if you sort of bear in mind those diffusion images, that's feeding that particular zone within the brain, within that junction. So tiny embolic phenomenon, acute diffusion restriction, no hemorrhage. This looks and smells like an infarct based on the imaging at this point in time. I also read the MRA and the MRA of the neck. I believe the following day, a colleague read the initial MRI, but I reviewed the initial MRI and then read the MRA of the head and neck, which were effectively normal.
And here is just 2.5 months later, just for comparison to show.
So follow-up 2.5 months later, you see on the left is the diffusion image, and on the right is the flare image. And the diffusion image at this point is effectively normal. There's no more acute diffusion restriction. It takes some time for diffusion signal to change. In the evolution of stroke, I showed you the initial image. The ADC map is dark when the diffusion images are bright. That's in the acute stage. In the subacute stage, the ADC map begins to become more gray, begins to normalize, if you will, and the dark signal becomes more intermediate and difficult to tell. And in the chronic stage, ADC images are effectively normal, and the ADC starts to go up, so that becomes bright. That's known as facilitated diffusion. Water molecules can now move again. The diffusion images are effectively normal, and the flare image shows some very residual hyperintense signal at the posterior insula. And at this point in time, it's probably very, very late stage as resolving edema, vasogenic edema, and some gliosis, which is a fancy neuroradiological term for scar tissue in the brain.
Great. Thank you so much for that review.
My pleasure.
So this person was acutely admitted to the ICU with all this information, and since some additional imaging that was done, again, the MRA of the brain and neck, no evidence of any type of arterial dissection. There was preservation of blood flow through the major vascular divisions. And again, the diffusion and flare sequences we already discussed did show that infarction in the left MCA territory. The CTA of the neck was similar findings, but also to add that there was no evidence of any aneurysms or any type of vascular malformation. Further ICU evaluations into what could have caused this. A bubble study was performed. It was suggested of a patent foraminal valley or a possible small atrial septal defect. This was again followed up with a transesophageal echo, which did show a small PFO. There was no thrombus within the heart. There was no normal biventricular function, and there was no plaque seen in the aorta. Further studies were done and because there was a thought that there could have been an embolic source for this event. And it did, the MR venography of the pelvis did show considerable clot burden in the bilateral common femoral, external iliac, as well as the left common iliac veins. Prior to being started anticoagulation, she did have a full panel of hypercoagulable studies. You name it, it was ordered, and all were negative. And again, there was no provoked activities that could have accounted for this, and there was also no family history of a clotting disorder. So the formal diagnosis from the initial presentation was a left parietal-temporal ischemic stroke, embolic source from pelvic DVT through PFO. The DVT was thought related to oral contraceptive use. That was the only thing found in her medical history that pretty much all the specialists agreed on that would have likely contributed to that presentation. Additionally, though, 3 days before, she did have that injury in the pool, and she did have a concussion without loss of consciousness from that subsequent to the CVA. So I think that's where the coincidence does come in, because initially it seems like the presentation was blending into itself, but when you actually follow from start to finish, she had an event, she had a concussion, she was being managed through that concussion, And then she did develop the right-sided numbness of her body as well as the word-finding difficulties, which then prompted a further evaluation. ICU and outpatient course summary. She was stable in the ICU. She had no worsening of symptoms, no motor deficits. She was started on Lovenox. She was discharged home in stable condition to physical therapy and speech therapy. The right-sided numbness and speech difficulty did resolve with rehab, which is great news for her being a 20-year-old. She was treated for depression and anxiety during this time because of everything going on, which is completely understandable. So it was a great job by our behavioral staff to pick up on this and help treat her through this very difficult time. Family members as well that were involved. The PFO was eventually closed a few months later with an implanted occluder. There was a repeat panel of hypercoagulable studies that were done, and again, they were negative. She did return to full academics, and the last time I spoke to her, she was unsure about playing sports again, but there was some talk about speaking to her team physician, and if she was off anticoagulation and things were going well, that there was a possible consideration for it. But again, I'm not going to comment further on that since I'm not the team physician for her institution, but that was her plan. So I get this question about once per week. Would you let your child play football? Great question. To be honest, my answer sometimes does change depending on what I've seen or heard from that week. And I'll explain why as I go further into the lecture portion of the topic. So quick facts about concussion. The CDC estimates about 1.6 to 3.8 million sports and recreation-related concussions occur each year in the U.S. That's actually a pretty significant number, wide range, but no matter what, even if it's 1.6, that's still pretty significant. Because she was a soccer player, just to point out that 5% of soccer athletes sustain brain injuries as a result of their sport. Goes to show she had 2 prior concussions that were sport-related prior to her not sport-related concussion. An athlete who sustains a concussion is about 4 to 6 times more likely to sustain another concussion, which is a well-studied and known fact. And I thought this was really interesting. So post-traumatic migraines after a concussion are fairly common. So when we're looking at her who has a history of migraine without aura, and I do bring that up because without aura, she was on an oral contraceptive medicine that did have an estrogen component to it. She, and it was kind of verified with neurology that she truly did not have an aura component to her migraine. It's interesting because after this happens, she really thought that later on this evening, yeah, maybe I have a concussion, but she was really concerned that she was having a migraine and that just, but then 2 days later, she started to develop these more, ominous symptoms. Again, pure coincidence based on how everything was looked at retrospectively, but at the moment in time, you can't really be sure. And that's why such a very thorough evaluation was done. And this was a multidisciplinary approach taking care of this patient. So acute concussion evaluation. So you're on the sideline, maybe it's a high school game, a college game, there's a concern for a concussion, what do you check first? And most answers always go C-spine. It's really challenging to move on to a full concussion evaluation without making sure that C-spine is clear. And what does that mean? We're looking to make sure that there's no obvious neck injury. That could be more concerning for a spinal cord injury because that will drastically change how you're going to triage that individual. We want to make sure that there's no midline tenderness, there's no neurological symptoms going to the bilateral or unilateral upper extremity, or even lower if there's something more substantial going on. So definitely make sure you're clearing the C-spine first as you're getting into your concussion evaluation.
Jason, can I just add something about that C-spine?
Yeah, absolutely.
So C-spine injuries, C-spine films can be I hate to say the word deadly, but they can be very misleading. Fractures can be very subtle. Many of us have learned in medical school that flexion teardrop, extension teardrop, hangman's, all these fancy eponymous fracture names. The reality of the matter is detecting fractures can be very difficult on plain films, especially if the films are not perfectly acquired. In patients who have neck pain, it's difficult to acquire perfect neck films. So if I always recommend if you have any degree of suspicion of spinal cord injury, there's neurologic dysfunction, at the very least get a CT, get an MRI if there's an appropriate mechanism, just because plain films can be difficult.
That's an excellent point. And actually Good sense. So some of the red flags. So now you're in your beginning phases of, you got called to check out this person with a concussion. Some of the red flags is to look out for: neck pain, midline tenderness, red flag. Someone with double visioning, loss of visioning, any type of weakness or numbness or tingling in the arms and legs really can't be accounted for. Severe and increasing headache, worst headache of your life. I'm sure we always ask that question. Seizures, convulsions, loss of consciousness varying upon time, any type of deteriorating conscious state, vomiting, someone who's restless, agitated, combative, or clearly becoming altered. Those are the case no matter who you are. If you're on the sideline, you're evaluating someone, you're really going to start to look at this person extremely closely about, is it appropriate to continue your evaluation there, or do you need to start thinking about, getting someone transported to an emergency department because you're dealing with something more, considerable. Common symptoms of concussion, not going to read them all out, but just to point out, there is a lot of overlap between C-spine injury symptoms as well as concussion. So, but also all your typical, common concussion symptoms are here, and this is the things that we're looking out for acutely when we're reviewing concussion. So concussion assessment continued. I already mentioned making sure you're clearing the C-spine, making sure you're clearing that neck, making sure there's nothing more significant going on there. You're looking at the head, making sure there's no obvious signs of injury to the actual scalp itself. You could be looking for signs of a skull fracture or scalp hematomas. The SCAT-5, that's your sport concussion assessment tool, version number 5. That's another commonly tool to use on the sideline. It has a Glasgow Coma scale function, a Maddox function for orientation, a cognitive screen, balance, etc. So it's a really good tool to be utilizing in an acute setting. When I'm seeing a patient for concussion, by time I'm looking at them on the sideline, I'm already looking, or the head and the neck are already done. I'm already asking them some components of questions that are on the SCAT-5 to check their orientation, and I'm getting into my neurological assessment, which does include a full cranial nerve assessment, cerebral testing, sensation and strength, deep tendon reflexes. I may not be full scope if it's an acute evaluation, but I do try to hit up some tending from DTRs. Balance error scoring system, as I mentioned in the beginning of the case, we'll go over balance in a double leg, single leg, and tandem stance, looking for errors compared to their baseline. We do have the benefit of doing this with their physicals for a lot of the athletes we see, so we can compare. Vestibular ocular motor screening we do on the sideline as well. That's pretty much what I would normally do for an acute sideline evaluation. When I'm seeing someone in the office, it does expand to the King-Devick testing as well as a Buffalo concussion treadmill test and impact testing. Again, you're looking at all these components to be able to diagnose someone with a concussion, because sometimes it's not really clear. Someone can simply just have a really bad neck strain presenting like a cervicogenic headache or a contact headache. Someone who has a low symptom score, who comes in with completely normal balance, completely normal vestibular ocular motor function, who's rapidly improving, may simply just be headache or an unspecified headache, or might be a cervicogenic component coming, from a neck sprain, but nothing significant, nothing that would warrant further imaging. But this is something to think about. All the tools that we would use to be able to do a rapid or in the office assessment of a concussion. And as you can see, all this was done except for the concussion treadmill test on this individual. This is just to point out, as we're going through a concussion evaluation, that when you look at every single part of the brain, everything that we're doing to evaluate concussion is actually being accounted for every single part of the brain. So we're checking sensation, we're over in the parietal lobe. We're looking at making sure their vision's intact, we're in the occipital. We're checking their balance, we're in the cerebellum. The first thing we're obviously looking out for too is if they're breathing. That's a huge red flag, of course. Again, brainstem, temporal lobe, behavior, memory, frontal lobe, emotional status, and, speaking, voluntary activity. So as you can see here, all the concussion assessment we're doing, we're covering, everything with our acute evaluation. And you can get a lot of information very fast. What I was just mentioning here, and I know Jay and I have literally done this, and Dr. Womack actually trained me in fellowship. This is something that we typically would be able to do within 2 minutes or less. We don't have to do it that way. It's more appropriate to spend more time, take the athlete away into a quieter place and get a better evaluation. But this stuff can be done rapidly to really get you a good rapid assessment so you can then triage your thoughts going forward. So acute management, don't, this is going to work 99% of the time, where removal from plane circumstance, you're never going to be wrong. Complete cognitive and physical rest, you're usually not going to be wrong. Plan for further clinical evaluation. So even for this person already, she was already removed from the circumstance. She was already doing cognitive and physical rest. And the further clinical evaluation was, this person definitely has more going on than just a concussion. She needs additional support. So just as something to think about if you find yourself managing an acute concussion. Now, be vigilant for C-spine injuries, as we kind of drove home already. The conservative approach is to assume the presence of a C-spine injury. You do that with spinal immobilization. Rigid cervical collar, backboard, and lateral head support is recommended. A lot of institutions are moving over to just a rigid cervical collar only approach with a padded stretcher. Again, that's more institution dependent, but there is some research that's maybe all you need. But some form of C-spine immobilization and protection should be maintained if you're concerned for a C-spine injury. There is a nexus low risk criteria for diagnosing or basically saying you do not need to do neuroimaging in a person with a C-spine injury. So typically if the person is less than 60 years of age, and they do not have midline tenderness, they have normal alertness, they have no evidence of intoxication, no abnormal neurological findings, and no painful distracting injuries, this person does not need advanced imaging of the C-spine based on the low risk nexus criteria. So again, something to think about if you find yourself triaging a case like this. Some of the advanced C-spine imaging, you would do a CT without contrast. That is preferred study, as Dr. Pawar already mentioned. You would do an MRI if the CT suggests an underlying ligamentous or spinal cord injury. Sometimes you can have negative radiographic findings, but you should still suspect a cervical ligamentous or spinal cord injury if there's severe neck pain that's not going away, if there's persistent midline tenderness and upper extremity neurological changes. So that would prompt an additional neuroimaging evaluation. Again, starting with a CT without contrast and moving on to an MRI if necessary. So brain imaging and concussions, typically you don't normally do, because for a non-complex concussion, you're not going to suspect any type of structural changes to the brain. So conventional neuroimaging is, not recommended for diagnostic purposes. There has been some newer studies with athletes actually having baseline MRIs of their brain done, and then after a concussion, looking at their post-concussion diffusion-weighted changes, and that there's some interesting research on that. Like, not in practice yet, but it is happening in studies in the NFL and other collegiate establishments. So just looking at triaging, again, some more brain imaging. So PCARN is the Pediatric Head Trauma CT Decision Guide. I have here the children 2 years of age or older one. There is one for children 2 years or younger, and this goes up to age 18. I adapted this from the California ACEP. Basically, this is a really unique card. Our SBMC emergency department, the pediatric EDs who work in the pediatric area, they actually use this criteria. So if someone came in who, let's just say, was 15 years of age, they would use this to determine if they would need a CT of their head. And you can start on the left side. You see if the Glasgow Coma scale is less than 15, there's signs of a basilar skull fracture or altered mental status. That person is high risk for a clinically significant traumatic brain injury and should get a CT scan. If none of that is present, you go on to the next step. You look for vomiting, loss of consciousness, severe headache, or severe mechanism of injury, which is usually a motor vehicle ejection, a rollover, or you're actually getting hit by an automobile. If yes, you have the option of doing observation versus doing a CT, but most physicians I spoke to basically would agree that it's still intermediate risk. It's still too much of a risk. A CT without contrast would typically be done of the head. This is one of the most commonly used decision guides that I found in the research. For adults 16 years of age and older, the Canadian head CT rule is usually what is used. There are other rules, but this is just the one that I see more widely used. This applies to patients with minor head injury who present with a Glasgow Coma scale of 13 to 15. You would typically have a witness loss of consciousness, amnesia, or confusion. The exclusion criteria, if you have a Glasgow Coma scale of less than 13, younger than 16, if you're on a a medicine that would cause bleeding or have a bleeding disorder or any obvious signs of an open skull fracture. This rule does have a sensitivity of 100% for picking up clinically important brain injury as well as intervening neurosurgically. So the sensitivity is good for this. And just as this is the final aspect of the actual rule itself, basically, if you have a Glasgow Coma scale score of less than 15 at 2 hours, CT, and you just follow it all the way down. So open or depressed skull fracture, CT, basilar skull fracture sign, CT. If you have 2 more episodes of vomiting, you do a CT. And even if you get into the medium risk for brain injury detection, you still amnesia before impact of 30 minutes or more, CT, dangerous mechanism, CT. I can tell you that I was covering a practice yesterday, and I actually utilized this criteria, and it fit quite perfectly. An individual who actually did not have a mechanism of injury came over to me and said, "Doc, I just don't remember anything for the last 30 minutes. Couldn't get a single play right. Don't really know where I am." He looked confused. He looked altered. He did not look himself. Went back, looked at the video, didn't really see a mechanism for it, but it was super concerning for how he was. So, over 16, he was having amnesia. His Glasgow Coma scale score, toyed with going between 15 and 14 a little bit. So there was enough with the head CT rule because of this to be able to send him for a CT scan of the head more acutely and just to show that everything was looking appropriate and still working that case up. So that's just an example of how this can be utilized not just in the emergency department setting, which we would typically see it in. You can use it to triage individuals if you're on the sideline, depending on what your resources are. So I'm going to move on to the panel and audience Q&A at this time. So I have again, thank you so much for the supportive panel being here today. I'm going to actually start out by asking Dr. Womack. Obviously this was a really challenging presentation for a concussion. Can you touch upon, any cases that you may have had with a challenging, complex presentation? Maybe give an example and see how it compares.
Yeah, thanks. Yeah, sometimes these concussions they're not your just straightforward sort of, global dysfunction. Sometimes they do get some specific functions. And I can remember at least 2 incidences over the last 15 years where we've had collegiate level athletes that have actually had ocular palsies, where they've had either ocular motor nerve palsies or other that were deemed to be related to concussion. And obviously these are folks that had focal neurological deficits, so they did get sort of that acute workup and got an MRI and had neurological follow-up with specialists. And in both these cases, it was deemed that these situations were related to concussion without any other, and it resolved over time with treatment of concussion. And then you've got other cases where you have non-contact stuff where someone's head may have been whipped around in the weight room, and that person ended up having a vertebral artery dissection as a cause of their headache. So, when you start getting into some of these folks that have some of these complicated symptoms, and, in the case of this gentleman with a headache, he didn't have any other focal symptoms other than headache. It just was the pattern of it and wasn't getting better. And it can be really challenging, but I think you have to have a threshold of, well, when you're not comfortable that this is just concussion. But the hard part about this, the vast majority of these extra workups you do show nothing. So you end up getting skewed to saying this is probably just concussion. And I think the hard part about the sideline is what it is. It's the sideline. So you don't have a great time for evaluation. It's all about follow-up. Following them for a period of time to make sure that they're getting better and they're improving. And if you don't see improvement, that should clue you off, or if anything else is worsening. And just to comment on one question that was in the Q&A before, someone had asked, is location of damage a consideration in your evaluation? And absolutely, for me, if it's in the temporal region, that area just has the bone is so thin in that area. So anyone with a hematoma or a significant blow to the head to that temporal region, I like to send off for further eval. We did have a collegiate level athlete at one point who it was a soccer game, got hit in that area and had a small hematoma develop and ended up having a subdural in that area. So those are sort of some of my take homes. A challenging case. It's so hard when you have everything screaming concussion and then say no, something else is going on, especially when they've had a couple of CTs. So very, very good case.
Okay, thanks, Dr. Womack. Dr. Yonclays and Dr. McKay, a similar question to Dr. Womack, and if either one of you can expand on any rehab challenges that this individual may have faced during the recovery.
Sure, I can start. That was a really good case, and concussion is very challenging. I agree with everything the panelists have been saying because there's so much overlap with concussion and so many other diagnoses like stroke and migraines and everything else. So really this case is just highlighting that, doing a great thorough neuro exam is key, because if there's anything concerning, you're never wrong by doing more of a workup. And there's definitely been, studies and plenty of cases where we know that the blow required to produce a concussion can also produce vascular injuries and could potentially lead to stroke and other things like that. So really needing to doing a great neuro exam is going to be so important. In terms of like rehab challenges, for this case in particular, if there's any intrinsic damage to the brain, we always worry about, what kind of residual effects she could have. And obviously she was in PT and speech for quite a long time and seemed to have resolved, but a concern for somebody her age would be what impact it may have in her academics. Would we potentially need to get neuropsych involved if she would need accommodations or anything like that? And it seems like she overall did pretty well, but those are things that we would definitely be worried about for her going forward. And there's some people who believe with, intrinsic brain damage that maybe you shouldn't return to, competitive sports again. So that's another thing, that a conversation that she'd have to have with her team physician. And, especially now that she's off of blood thinners, but definitely when she's on blood thinners. But overall, she's definitely going to need more therapy than somebody who just had a concussion. And I think for her, academics and kind of return to school would be key.
Yeah, and I would agree with everything. I think we're running short on time. I think I would add, she was very fortunate that her lesion version, like Dr. Pawar said, it was very small. So a small lacunar injury. So you would expect that to get better, but as Dr. McKay mentioned, there is concern with gliosis or scarring, as Dr. Pawar said, that could potentially make a return to impact contact sports her more susceptible to shear injury. If you want to think that the scar area doesn't move as well, that she would be at greater risk. But I think the tough thing in kind of returning her even to academics, you did a great job with having her followed along by speech therapy. There's going to be a lot of overlap with concussive symptoms, word finding difficulties with really a complex concussion sometimes. And you want to just be cognizant of that as you go forward.
Great, thank you. It's great feedback, everyone. Dr. Mike, so when people come to start concussion rehab with you and that you do initial evaluation, what red flags are you typically screening for and look out for? Because I know there's been a few times where you picked up on things and had to refer them right back to the physician.
Yeah, I think the big thing in physical therapy is that, we rarely are that first contact. They've been evaluated by the ED, they've been evaluated by an MD, and we have some sort of baseline information on how they're presenting. And the first thing in physical therapy is, our red flags is, are you changing? Are you evolving? And this is just taking longer to change, and we're missing some of those red flags that you thoroughly reviewed earlier in your initial evaluation. The nice thing about the post-concussion survey is it does cover a lot of those symptoms, and we're seeing if they're changing. On a physical therapy standpoint, like you said, a lot of concussion symptoms and neck symptoms both overlap. So we're going to reevaluate that C-spine and see if that's evolving, especially those ligamentous stability tests, because if they're so guarded from that whiplash injury, those aren't really reliable until later on things start to calm down. And we've definitely had to refer out for concerns of ligamentous instability later on. The other one from a physical therapy standpoint that we want to rule out quickly is BPPV. Actually, and we don't think about that because it's really not life-threatening in the beginning. But if that's a real concern, we're going to try and rule that out quickly because it's going to affect their care almost immediately. And that's something that really doesn't get tested for until you're 1 week out, 2 weeks out, even though it's affecting them very significantly.
Great. Thanks, Dr. Mike. So there's some great panel questions I just want to, or some Q&A questions. So I'll take the first one. Should post-traumatic headache diagnosis always include some form of graduated return to play? Great question. The first thing is making sure that the proper diagnosis is post-traumatic headache and not something like a concussion or something more significant. So as Dr. Womack was alluding to, it's all about the follow-up. So, with our collegiate patients, we have the availability of literally seeing them once a day, twice a day if we wanted to, the next day. So when, we basically see that symptom score trending down, we know that there's no vestibular, ocular, or balance issues, and, they're doing academics, smoothly. We typically would do an exertional test on them, let it be a bruise test or a physical exertion test, where we just want to make sure that they can be highly exerted without having any type of new or increasing symptoms. And then from there, we actually clear them for return at the discretion of their team athletic trainer to, if they need another day or two, but not a formal return to play, but we do stress them exertionally prior to giving them a clearance to go back. The benefit in collegiates is that we have full access to athletic trainers and staffs and coach. So if anything changes, we can immediately pull them harder in the outpatient when, it's harder to do follow-up with an individual at the high school or the middle school level. Another great question that came through on the chat, was, is there any BP or heart rate variability analysis that's done for sideline evaluation, or was there anything with her case that could have, clued us into it? She did not have any BP or heart rate availability for time considerations. I didn't include vitals on this presentation, but she did not show any signs of autonomic dysfunction. But again, that was something that we would have picked up better during the treadmill testing phase when we do serial, blood pressures, or in the rehab phase that we do serial blood pressures. But again, for this purposes, that was not done. But typically in the sideline, we do not do a heart rate variability test. Depending on the situations, we may have to check into acute blood pressure, depending on what we're dealing with. But it's not always present. Let's see. I don't see any other questions in the chat box or within the Q&A, though. I'm gonna, before I pass it over to Diana, I hope everyone enjoyed this unique case. I think some of our panels were talking before and said this is something maybe you see once in 20 years. I think it was an excellent job by everyone involved with this person's care for her to have a great, safe outcome. I hope you guys found that the format today of the case presentation, a little bit more about neuroscreening and neuroimaging, was helpful. And, any additional questions, I'd be happy to, have a reach out through email or through the center. And I think I would like to close with the takeaway is I've been saying this since I was a medical student, and, sometimes being precisely right, sometimes that's not the exact thing you need to do. I know it's kind of a weird message, but my goal is to just never be wrong. There are certain things in any type of medicine, and especially in sports medicine, that if you miss, it could, or any type of medicine, it could just be really bad. If you're looking at someone who's presenting as a really bad COPD exacerbation, and they have a submassive pulmonary embolism, right? So I just looked, the way I presented this case was I just never want to be wrong. And I knew that being wrong would have been not doing something more for this individual, assuming that it was just a complex concussion or a migraine with a complex presentation. So that's how I approached it. And I hope the way we presented it was helpful. Again, I want to thank the panel for being here. Thank you for the audience. Looking forward to presenting on additional sports medicine grand rounds in the future, as well as our symposium coming up, which they haven't heard about it yet, but all the panelists will be going to be asked to be on that symposium. So there you guys go. Diane, I'm going to pass it back over to you.
All right. Well, everybody, I second everything Dr. Krystofiak said today. Thank you to the panel and everyone for being here. I truly am just so proud to work with these physicians. They are truly amazing. I mean, the brain injury medicine around this case is extraordinary. And, I think we're all very proud to be part of this team. And this was a huge win, Dr. K. So awesome job all around from everybody that was involved in this case. Thank you everyone for your time. And please keep a lookout for future sports medicine grand rounds programs, our upcoming seminar in the fall, and happy Mother's Day to all the moms out there. Have a great weekend, everybody. Thanks so much.